Hi everybody, and welcome to our module on acid-base principles. The normal pH of arterial blood ranges from 737 to 7.42, and this is tightly controlled via a process called acid-base balance because you need the pH in this range for all the enzymes and cells of the body to work. The two important organs for acid-base balance are the lungs and the kidneys. The lungs excrete carbon dioxide to modify the pH, and the kidneys excrete acid and produce bicarbonate also to maintain the normal pH. Shown on this slide is the Henderson-Hasselbalch equation for human plasma. And this equation says that the pH varies with the concentration of bicarbonate and the partial pressure of carbon dioxide in the arterial blood. And as we just talked about, the bicarbonate is controlled by the kidneys and the carbon dioxide is controlled by the lungs. So basically what this equation is telling you is that as the carbon dioxide level goes up and down, or as the bicarbonate level goes up and down, these things will have effects on the pH. So the way we determine the acid-base status for a patient is by doing what's called an arterial blood gas. This involves sticking a needle into the radial artery in the arm, like shown on the screen here, and drawing a sample of arterial blood, and then that's sent to the lab. And from that sample you can determine the bicarbonate level in arterial blood, the carbon dioxide level, and also the pH. A normal bicarbonate level is 22 to 26, a normal carbon dioxide level is 35 to 45, and as we've already said, a normal pH is 737 to 742. And most people just remember these numbers shown on the slide here. A normal bicarb is 24, that's the middle of the range. A normal PCO2 is 40, and a normal pH is 7.4. And it's helpful if you actually memorize these numbers because it makes it much easier to solve acid-base problems on your board exams and also to quickly evaluate your patients. So an acid-base disorder is a pathologic process that causes the pH to become above or below the normal range. And when we say someone has an acidosis or an alkalosis, what we mean is they have a disorder that's altering the proton levels and therefore altering the pH. When we say someone has an acidemia or an alkalemia, what we mean is they have either a low or a high pH in the bloodstream. Now usually when you have an acidosis you also have an acidemia, and when you have an alkalosis you also have an alkalemia, but there are some exceptions, and these are called mixed disorders. So if you have an acidosis with an alkalosis at the same time, then you might not necessarily have acidemia, and we'll talk about mixed disorders later in this module. So I told you earlier that the body tightly maintains the pH of plasma because within that range all the enzymes and cells of the body can function normally. Well, now let's talk about what happens if the body gets outside of that pH range, and we'll start by talking about some of the clinical effects that occur when patients develop an acidosis. So first of all, any patient who is acidotic should be hyperventilating, assuming their lungs are working normally. If you look at the bottom of the screen, in patients who are acidotic, the pH gets low, and the response of the body is to hyperventilate so that the PCO2 will fall, and when the PCO2 falls, the pH goes back up towards the normal range. So hyperventilation to lower the PCO2 is the normal response to acidosis. And therefore, acidotic patients should always be hyperventilating unless they have a respiratory acid-base problem where their lungs are not working normally. Another effect of acidosis is myocardial depression. Severe acidosis can decrease myocardial contractility. I once saw a severely acidotic patient from renal failure who had a pH of 7.1. That patient had such a low cardiac output that they were in shock. It wasn't a problem with their heart. The entire problem was the acidosis affecting the myocardial contractility. Acidosis also causes cerebral vasodilation. So you may recall from physiology that carbon dioxide is a major cerebral autoregulator. And the way carbon dioxide regulates blood flow in the brain is that when the carbon dioxide level goes up, there's more blood flow to the brain. What you need to know, however, is that the way carbon dioxide controls the cerebral blood flow is by changing the pH. So anytime carbon dioxide levels in the brain go up, that lowers the pH of the cerebrospinal fluid, and that's what increases cerebral blood flow. So anytime the pH of plasma falls, that's going to lower the pH in the brain, and the brain's going to interpret that as thinking there's more carbon dioxide around, and therefore cerebral blood flow will go up. So cerebral vasodilation is seen in any acidosis, and it can lead to high intracranial pressure, and clinically this means patients can develop headaches. And then finally, hyperkalemia commonly occurs together with acidosis. The reason for this is that when there is lots of acid around, there are lots of protons outside of cells, and cells have an exchanger of protons and potassium. So when cells are surrounded by lots of hydrogen ions in an acidosis, hydrogen ions will get pulled in and potassium will get pushed out. And it's this potassium coming out of cells that will cause hyperkalemia that is associated with many types of acidosis. The clinical features of an alkalosis are generally the opposite of an acidosis, so patients who are alkalotic should be hypoventilating unless they have a respiratory disorder. Alkalosis causes cerebral vasoconstriction, so there's a fall in cerebral blood flow, and alkalosis is associated with hypokalemia. We divide acid-base disorders into two types, metabolic disorders and respiratory disorders. In metabolic disorders, the problem is bicarbonate. There's either too much or too little bicarbonate, and that is affecting the pH. When there's not enough bicarbonate around, the pH gets low. That's called a metabolic acidosis. And when there's excess bicarbonate, the pH gets high, and that's called a metabolic alkalosis. In respiratory disorders, the problem is excess or insufficient PCO2. So we call it a respiratory acidosis when the CO2 level gets high, because this tends to lower the pH and cause an acidosis. When the CO2 level gets low, that causes a respiratory alkalosis and a high pH. So on your boards and in clinical practice, you're going to be faced with what's called an acid-base problem. This is a situation where you're given the pH, the carbon dioxide, and the bicarbonate, and you're asked what is the underlying disorder. So that's what we're going to talk about for the remainder of this video. So when I'm faced with an acid-base problem, there are a series of steps I go through in my mind to determine what the underlying cause of the acid-base disorder is. So let's go through those now. The first thing I recommend you do in an acid-base problem is check the pH. If the pH is less than 7.37, then you have an acidosis present. If the pH is above 7.42, then you have an alkalosis present. After this, you should next check the levels of bicarb and PCO2 and ask yourself whether these are increased or decreased. Remember, the normal range for bicarb is 22 to 26, with 24 being the midpoint. The normal range for PCO2 is 35 to 45, with 40 being the midpoint. Once you know the pH and whether the bicarbonate is increased or decreased and whether the CO2 is increased or decreased, you can then determine the acid-base disorder. If you have an acidosis based on pH and the bicarb is low, then you have a metabolic acidosis. Because a low bicarbonate, if you look at the Henderson-Hasselbalch equation, a low bicarbonate will cause the pH to get low, and therefore you've got concordance between the fall in bicarbonate and the fall in pH, and that means you must have a metabolic problem with bicarbonate, and that's a metabolic acidosis. If, on the other hand, you have a low pH, meaning an acidosis, and the CO2 is high, then that means the CO2 is the cause of the acidosis, and therefore you have a respiratory acidosis. And then, of course, the opposite of these things are true. If you have an alkalosis and a high bicarbonate, that's a metabolic alkalosis. If you have an alkalosis and a low CO2, that's a respiratory alkalosis. And all of this is based on the Henderson-Hasselbalch equation. So those first three steps are really the main steps in solving acid-base problems. These last two steps, 4 and 5, are sort of add-on steps for special situations. If you have a metabolic acidosis, then you must calculate the anion gap. And I talk about this in detail in the video on metabolic acidoses. And then there are special formulas you can use to check for a mixed disorder. So for example, you could have a combined respiratory and metabolic disorder, or you could have two metabolic disorders. At the end of this video, I'll talk a little bit about how to work up mixed disorders. So in a minute, we'll go through some examples of acid-base disorders, and I'll walk you through how to solve them. But before I do that, let me talk about compensatory changes. So changes in bicarbonate and carbon dioxide are not independent. When the bicarbonate becomes abnormal, that triggers a response from the body, and that will lead to an abnormal CO2 level. The opposite is also true. When there's an abnormal carbon dioxide level, this will trigger a response leading to an abnormal bicarbonate. So these changes where an abnormal bicarbonate or CO2 causes an abnormality in the other parameter, these are called compensatory changes. So in a respiratory disorder, you have an abnormal carbon dioxide. Respiratory disorders are lung problems. So the compensation is going to come in the form of bicarbonate from the kidneys. If you look at the bottom of the screen, imagine that the CO2 level goes up and this affects the pH. The kidneys are going to respond by changing the bicarbonate to try to bring the pH back to normal, and that's called a compensatory change of the kidneys in bicarbonate in response to a change in carbon dioxide. In a metabolic disorder where you have an abnormal bicarbonate, the compensatory change comes from the lungs. The respiratory system will modify the level of CO2 again to try and bring the pH back towards normal. So in this summary slide, I've shown the 4 different types of acid-base disorders and what the primary abnormality is and what the compensation is. So in a metabolic acidosis, remember, metabolic disorders are always bicarb problems. In a metabolic acidosis, the bicarbonate will fall because when the bicarbonate level falls, that lowers the pH, causing an acidosis. The compensatory response is a fall in CO2 because if the CO2 level goes down, that tends to raise the pH back towards the normal range, and that's why this is the compensatory response. In a metabolic alkalosis, the problem is that the bicarb level is high and the compensation is a high CO2. In respiratory problems, the issue is with carbon dioxide. In respiratory acidosis, the carbon dioxide is high. In respiratory alkalosis, the carbon dioxide level is low. The compensatory response in these situations is modification of the plasma bicarbonate. So putting this all together, in most acid-base disorders, both the bicarbonate and the carbon dioxide are abnormal. One of the changes is the culprit, meaning it's causing the acid-base disorder. The other change is the compensatory response, trying to correct the acid-base disorder and bring the pH back towards normal. So in simple acid-base disorders, which are very common acid-base disorders, the culprit and the compensatory change is in the same direction, meaning that both the bicarbonate and the CO2 are either increased or decreased. So let's take a look at this example on the screen. Imagine a patient has a pH of 7.3. That patient must have an acidosis present. Now imagine that the bicarbonate is low and the CO2 is low. Since both values are low, this means we have a simple acid-base disorder. We do not have one of those complex mixed disorders. A low bicarbonate causes an acidosis, and we have an acidosis, so this must be a metabolic acidosis. A low CO2 does not cause an acidosis, that causes an alkalosis. So therefore the low CO2 must be the respiratory compensation and the compensatory change. And again, if you look at the Henderson-Hasselbalch equation, the idea here is that in this example, the bicarb is low, which lowers the pH, and therefore the system responds by lowering the CO2 level, which raises the pH and tries to bring it back to the normal range. Here's another example. Once again, the pH is 7.3, that's below the normal range, so there's an acidosis. But in this case, the bicarbonate is high and the CO2 is high. Well, a high bicarbonate causes an alkalosis, not an acidosis, so this cannot be the cause. A high CO2, however, does cause an acidosis, so therefore what we've got here is a respiratory acidosis caused by the high CO2 level with metabolic compensation, that is a high HCO3 level, trying to bring the pH back towards the normal range. Very important that when faced with a simple acid-base disorder, you are able to quickly determine which change, bicarbonate or CO2, is the culprit and which change is the compensatory response. So now let's drill down in a little more detail and talk about how the body compensates for acid-base disturbances. And we'll start by talking about respiratory compensation. So respiratory compensation for a metabolic disorder is always either hyperventilation or hypoventilation. By changing the amount of alveolar ventilation, this is going to alter the carbon dioxide level, and that's the way that the body compensates for metabolic disorders when the bicarbonate is abnormal. One of the classic examples of this is something we've already talked about, that's hyperventilation. This is the physiologic response to metabolic acidosis. And if you ever see a patient with diabetic ketoacidosis, for example, where the pH is very low, that patient will be taking rapid, deep labored breaths. These are called Kussmaul breaths. And this is all an effort to try and blow off carbon dioxide and get the pH to climb so it comes back to normal. So hyperventilation, especially deep labored hyperventilation, is a classic response to a severe acidosis. And that's the lungs trying to compensate for the fact that the bicarbonate level is very, very low in a metabolic acidosis. So in general, hyperventilation as a compensatory response to an acid-base disturbance blows off CO2 so the plasma CO2 level falls. This causes less acid to be present in the blood and the pH rises. If you look at the Henderson-Hasselbalch equation, hyperventilation will lower the CO2. That is going to tend to raise the pH, and therefore that's a response when the body is in an acidotic state. Hypoventilation causes the retention of CO2. Plasma CO2 level rises and there's more protons in the blood, and this will lead to the pH falling. And this is a response when there's a metabolic alkalosis. So now we've talked about how the respiratory system tries to compensate for acid-base disturbances. Now let's switch gears and talk about the renal compensation for acid-base disorders. So when there's an acidosis, the kidneys will try to increase the serum bicarbonate. If you look at the Henderson-Hasselbalch equation, if you have a low pH in an acidosis, what the kidneys will try to do is manipulate the bicarb level and raise this so that the pH goes back towards the normal range. There are a couple of things the kidneys can do to raise the bicarbonate level in the plasma. First of all, the kidneys will filter and secrete all the protons they can to try to get as much acid as possible to go out in the urine. So the urinary pH should get very low in the setting of an acidosis if the kidneys are working normally, because they're trying to excrete acid. In addition, the kidneys will make sure they reabsorb all the bicarbonate that they can. And then finally, the kidneys are able to generate bicarbonate. So in the setting of an acidosis, they will produce more bicarbonate. In the setting of an alkalosis, the reverse of an acidosis happens, and the kidneys will try to excrete more bicarbonate. The time frame of the compensatory responses by the lungs and the kidneys is very different, so let's talk about that now. In respiratory compensation for a metabolic disorder, meaning when the lungs try to change the ventilatory rate in response to a change in bicarbonate from a metabolic disorder, this type of change can happen very quickly in a few minutes. So patients who develop an acidosis can modify their respiratory rate very rapidly, and in just a few minutes you can see them begin to breathe quickly. So a patient who has a change in the bicarbonate from a metabolic disorder can have a response with a change in the CO2 level within a couple of minutes of the onset of that metabolic disorder. In contrast, when the kidneys try to compensate for a respiratory disorder, this response is much slower. It takes a few days for the kidneys to modify the amount of bicarbonate they excrete or reabsorb. So if a patient develops an abnormal CO2 level from some type of respiratory disorder, you're not going to see a significant change in the bicarbonate for a couple of days. There are some very rapid short-term changes that are small that can occur from buffering, but these are minor changes. The big changes in the serum bicarbonate of metabolic compensation to a respiratory disorder take several days to develop. I'll finish this video by talking about mixed disorders. So mixed acid-base disorders are when there are two disorders occurring at the same time. For example, patients can have a metabolic acidosis and a respiratory acidosis, or a metabolic acidosis and a metabolic alkalosis, or they could have two metabolic acidoses. And this occurs in many pathologic states. For example, vomiting causes a certain set of acid-base problems, and so does diarrhea, and many patients develop vomiting and diarrhea at the same time, so that's going to lead to a mixed disorder. So the way to handle mixed disorders is to determine the expected response. So for example, if you have a respiratory alkalosis or acidosis, as we will see, there are formulas that can tell you what the expected bicarbonate should be. Or if a patient has a metabolic disorder where the bicarb is high or low, there are formulas that can tell you the expected carbon dioxide. If the actual level does not equal the expected, then you must have a second disorder present. And one sort of general rule of thumb is that compensation back to a normal pH is very rare. It can happen in some circumstances, but it's extremely uncommon. So if you see a patient who has a very high bicarb or a very low CO2, but their pH is normal, this almost always means there's a mixed disorder, and this is a rule of thumb you can sort of follow. So as I said, if the actual number does not equal the expected number, then you have a mixed disorder. Once you know that, you need to determine what the abnormality is causing the mixed disorder. For example, is the CO2 higher than expected? That implies one set of mixed disorders. Or is the bicarb lower than expected? That applies something else. Once you do this, the usual rules apply for determining the secondary disorder. If you have a CO2 that's higher than expected, then you must have a concomitant respiratory acidosis. The CO2 is lower than expected, you have a respiratory alkalosis as a second disorder. Low bicarbonate implies a secondary metabolic acidosis, and high bicarb implies a secondary metabolic alkalosis. So there are compensatory formulas that you can use to determine the expected carbon dioxide or bicarb for a given acid-base disorder. I've written the four important ones on the slide here. Most of these do not come up in your STEP exams. I'll talk only about the first one, Winter's formula, which is what I think is the most important one to know. This one is very easy to apply, and it may come up in your board exams. So Winter's formula is used only in a metabolic acidosis. Always remember that. Only when your patient has a low pH, meaning an acidosis, and a low bicarbonate, meaning a metabolic acidosis, only in this situation do you apply Winter's formula. And what Winter's formula is going to do is tell you what the CO2 level should be, because the compensation for a metabolic acidosis is a respiratory alkalosis, meaning a low CO2 level. As we talked about before, when there's a metabolic acidosis, that should trigger hyperventilation and the CO2 level should be low. So Winter's formula will calculate the expected CO2 that you should have, and if this doesn't match the actual CO2, then you have a mixed disorder. And this is Winter's formula at the bottom of the screen. It says that in a metabolic acidosis, the CO2 level should be 1.5 times the bicarb plus 8 plus or minus 2. The easiest way to understand Winter's formula is to go through a couple of examples. So let's imagine we have a patient with a pH of 7.23 that's below the normal range, so this patient has an acidosis. The bicarb is 9, which is low, so therefore this must be a metabolic acidosis. And in any metabolic acidosis, you can apply Winter's formula to see if the carbon dioxide level you have matches what is expected. So according to Winter's formula for this patient, the expected carbon dioxide is 1.5 times the bicarb of 9 plus 8 plus or minus 2. And this works out to 22 plus or minus 2. And our carbon dioxide level is also 22, so therefore it's within this range. And this means we do not have a second acid-base disorder. We have a simple metabolic acidosis with normal respiratory compensation. Here's another example. In this case, we have a pH of 7.1, which is low, so we have an acidosis present. The bicarb is 12, which is also low, so this means once again we have a metabolic acidosis. Now the question we want to answer is there anything else going on? Do we just have a simple metabolic acidosis, or is there another disorder present as well? The PCO2 is 40, and right away this suggests that there is probably a second disorder. The reason is that you should never have a normal PCO2 in the setting of an acidosis. This is very unusual. So probably we have a second disorder, but let's go ahead and prove it with Winter's formula. So we apply Winter's formula, which tells us the expected PCO2 is 1.5 times the bicarb of 12 plus 8 plus or minus 2. And this works out to 26 plus or minus 2. So our actual PCO2 of 40 is higher than the expected PCO2. This means we must have a second disorder present in addition to the metabolic acidosis. And the type of disorder that causes your PCO2 to be too high is a respiratory acidosis. So in this example here, example number 2, we have a metabolic acidosis with a concomitant respiratory acidosis. And the way we were able to uncover the secondary disorder is through applying Winter's formula. So I'll finish with this summary slide and review the 5 steps for solving acid-base problems. So step 1 is to check the pH. If the pH is below the normal range, that's an acidosis. If it's above the normal range, that's an alkalosis. Next, you want to check the bicarbonate in the PCO2. If you have an acidosis and a low bicarbonate, then you have a metabolic acidosis. If you have an acidosis and a high PCO2, then that's a respiratory acidosis. If you have an alkalosis and the bicarb is high, that's a metabolic alkalosis, and an alkalosis with a low CO2 is a respiratory alkalosis. The 4th step is to calculate the anion gap. This is only required in metabolic acidoses. And the last step is to use special formulas to check for mixed disorder. We talked about Winter's formula in this video. I've listed the other special formulas here. You can read about them if you wish. And that concludes our module on acid-base principles.